Welcome to the deep dive. Today, we're really going deep into a system that's just fundamental to our existence, the vascular system. And of course, the many ways things can go wrong with it, the pathologies.
Absolutely. It's a massive area. Disruptions in our blood vessels, whether they're slow and progressive or sudden and dramatic, they have huge consequences for health, for longevity.
Definitely. So we'll be looking at those two main problems, right? Either the vessels narrowing or getting blocked completely, or the walls weakening, leading to, well, dangerous blowouts or tears.
Exactly. And to really get those disease processes, you absolutely have to start with the normal. You need a really clear picture of how healthy vessels are built and how they function.
Like needing the building blueprints before you can figure out why the walls are cracking.
Precisely. It's the foundation for understanding everything else.
Okay, so let's unpack this. Our goal today is, well, ambitious. We want a really granular understanding, not just a surface skim. We're going to meticulously look at vessel structure, function arteries, veins, lymphatics. Then dive into big players like hypertension, arteriosclerosis, explore aneurysms, vasculitis.
Hyperreactivity disorders, too. Don't forget those.
Right, those as well. And venous and lymphatic problems, vascular tumors, and even what happens when we try to fix things, the pathology of interventions. We want to build this knowledge base, piece by piece, aiming for that elite professional level of understanding.
It's a tall order, but essential.
So to start building that foundation, where do we begin with normal vessel structure?
Well, the starting point is the general three-layered architecture you find in almost all blood vessels, arteries, and veins anyway. You've got the intima on the inside, the media in the middle, and the adventitia on the outside.
Capillaries, you mentioned.
Right. Capillaries are simpler, stripped down for exchange. But for the others, those three layers are the rule. And the main cellular players throughout are endothelial cells, or ECs, and smooth muscle cells, SMCs, all embedded in this extracellular matrix, the ECM.
Intima, media, adventitia.
Yeah.
Okay, but, the aorta must be built very differently from a tiny vein, right?
Yeah.
How do these layers adapt?
They absolutely do. The structure is tailored to the job. Take arteries and veins at the same branching point. Arteries always have thicker walls.
Makes sense. They're handling higher pressure, that pulsatile flow from the heart.
Exactly. They need that strength to withstand the pulse and the pressure.
So they absorb that initial force. What happens further down the line as arteries get smaller?
Okay, so as arteries branch and get smaller, the overall wall thickness does decrease naturally. And this is really key, the ratio of wall thickness to the lumen diameter actually increases.
Wait, the ratio increases. How does that work?
It seems a bit paradoxical, doesn't it? But it means these smaller vessels, especially the arterioles, have proportionally thicker muscular walls relative to their opening. This gives them incredible control over blood flow and resistance. They're the main regulators.
So they're like the control valves, managing flow into different tissues and regulating overall pressure.
Precisely. And this structural specialization directly impacts disease patterns. Certain conditions just prefer certain types of vessels.
For example?
Well, atherosclerosis, which we'll get into, loves the big elastic arteries like the aorta and the medium muscular ones like the coronaries. Hypertension, on the other hand, really does its damage in the small muscular arteries and arterioles.
Okay.
And vasculitis, the inflammatory diseases, they often target vessels of a specific size, a specific caliber. So the anatomy dictates the vulnerability in many ways.
Like different parts of the plumbing system having their own weak points. Now, you mentioned the core components, endothelial cells, ECs, smooth muscle cells, SMCs, and the extracellular matrix, ECM. Let's break those down.
Okay. Endothelial cells, they form that continuous single-cell lining inside all blood vessels. They're the direct interface with the blood. Smooth muscle cells, mostly in the media layer, give the vessel structural support and the ability to contract and relax, changing the diameter.
Vasoconstriction and vasodilation.
Right. And the ECM is the scaffold, the glue holding it together. It's made of things like elastin for stretchiness, collagen for strength, and glycosaminoglycans for cushioning and hydration. The mix of these components, the proportions, the arrangement, it's all customized depending on the local pressures and needs.
Highly tailored design. Okay, let's zoom in on those three layers again. Intima, media, adventitia. Starting with the intima.
The intima, when it's healthy, is pretty simple. It's just that single layer of endothelial cells sitting on a thin basement membrane with a little bit of ECM underneath. And importantly, it's separated from the next layer, the media, by the internal elastic lamina, a distinct sheet of elastic fibers.
Okay, clear boundary. Then the media, the muscle layer. How does that differ between, say, the aorta and smaller arteries? Let's start big with the aorta.
The aorta's media is really quite amazing. It's organized into what we call lamellar units. Think of them like concentric rings, maybe like tree rings. Each ring is a composite structure of elastin fibers interwoven with smooth muscle cells.
Lots of elastin then.
A lot of elastin. This lets the aorta stretch significantly during systole, when the heart pumps blood out, and then snap back recoil during diastole. That recoil is crucial. It helps smooth out the pressure pulse and maintain blood flow even when the heart is relaxing.
So it's not just a passive pipe. It actively helps blood flow. But you implied this elasticity doesn't last forever.
No, unfortunately not. With age, those elastin fibers tend to degrade. They fragment. It's called elastolysis.
Yeah.
This loss of elasticity makes the vessel wall stiffer, less compliant.
So it can't absorb the pressure wave as well.
Exactly. Which leads to higher systolic pressure, a wider pulse pressure. And these stiffer vessels can also become elongated and twisted tortuous and develop a sort of diffuse widening called ectasia.
So the age-related rise in blood pressure isn't just plaque buildup, it's also the vessel wall itself changing. Okay, now let's compare that to the muscular arteries, like the coronaries or the renals. How's their media different?
In muscular arteries, the media is dominated by smooth muscle cells, and they're mostly arranged circumferentially, wrapped around the vessel. This structure gives them their main job, contracting to narrow the lumen vasoconstriction and relaxing to widen it vasodilation.
Controlling blood flow distribution.
Precisely, adjusting flow to different organs based on their needs. And this is regulated by the autonomic nervous system and also by local signals from the tissues themselves.
So elastic arteries handle the main pressure surge. Muscular arteries distribute the flow. What about the smallest ones, the arterioles? You called them the main site of resistance. Why?
It comes down to physics, specifically Poiseuille's law. Resistance to flow is inversely proportional to the fourth power of the radius.
Or the fourth power.
Yeah, which means even tiny, tiny changes in the diameter of these arterioles have a massive impact on overall resistance in the circulation. A little bit of narrowing dramatically increases resistance. A little widening drops it significantly. They are the fine-tuners for blood pressure and local flow control.
That exponential relationship really highlights their importance. Okay, the outermost layer, the adventitia, what does it do?
The adventitia is basically the connective tissue wrapping around the outside. It anchors the vessel to the surrounding tissues. It's mostly loose connective tissue, collagen, some elastic fibers. In bigger vessels, it's often separated from the media by another elastic layer, the external elastic lamina.
Any other key features?
It contains nerve fibers, and critically, in larger vessels, it houses the vasa vasorum.
The what?
Vasa vasorum, literally vessels of the vessels. It's a network of tiny arterioles and capillaries that supply blood to the outer layers of the media itself.
Ah, so the vessel wall needs its own blood supply.
The outer parts do, yes. The inner layers and thinner vessels can get enough oxygen and nutrients just by diffusion from the blood flowing inside the lumen.
Okay. Now, we focused on arteries. How do veins compare structurally side by side?
Veins, compared to arteries at the same level, usually have a larger diameter, a bigger lumen, but their walls are significantly thinner and less organized, less muscular and elastic.
Why the difference?
It reflects their main job. Veins are capacitance vessels. They hold a lot of blood volume. Maybe about 2/3 of your total blood volume at any given moment is in your veins. They don't need to withstand high pressure like arteries.
So arteries focus on pressure and delivery, veins on volume and return.
That's a great way to put it. And to help get that blood back to the heart, especially from the legs against gravity, veins have one-way valves inside them.
Like little check valves.
Exactly, usually bicuspid flaps made from the intima. They snap shut to prevent blood from flowing backwards. Arteries don't need them because the heart's pumping pressure keeps things moving forward.
Makes sense. Now, we skipped over capillaries earlier. They're the site of exchange, right? Tiny things.
Incredibly tiny. Their diameter is actually smaller than a red blood cell, around 5 micrometers versus 7 or 8 for the cell. Red cells have to squeeze through single file, which maximizes surface area for exchange.
And their walls must be super thin.
Extremely thin, just a single layer of endothelial cells on a basement membrane. No real media or adventitia. They do have these cells called pericytes wrapped around them, which offer some support and might influence permeability.
So, thin walls, slow flow. Ideal for diffusion.
Perfect for diffusion. The total cross-sectional area of all the capillaries in your body is enormous, so the blood flow slows right down. Slow flow, thin walls, great for swapping oxygen, CO2, nutrients, waste products between blood and tissues.
And I assume tissues with higher metabolism need more capillaries.
Absolutely. A heart muscle, the brain, they have incredibly dense capillary networks. Because oxygen can only diffuse effectively about 100 micrometers from a capillary, you need them packed closely in active tissues.
That limit really drives home the need for that density. Okay, so after the capillaries, blood heads back via the venules.
Correct. From capillary beds into the smallest venules, the postcapillary venules then into collecting venules, and eventually larger veins. An important point about postcapillary venules, they're the main site where fluid leaks out and white blood cells exit during inflammation.
Why there specifically?
Their endothelial junctions are just inherently a bit looser, more permeable, especially when inflammatory signals are around.
Interesting. So they're key players in the inflammatory response. Finally, the lymphatic system. It runs alongside but does something different.
Yes, it's a parallel drainage system. Lymphatics are thin-walled channels, also lined by endothelium, that pick up excess interstitial fluid called lymph from the tissues. Lymph contains water, proteins, fats, immune cells.
And where does it go?
It travels through a network of lymphatic vessels, gets filtered through lymph nodes, and eventually returns to the bloodstream via the thoracic duct and right lymphatic duct, which empty into the big veins near the heart.
So fluid balance and immune surveillance.
Exactly. It transports immune cells to lymph nodes where they can get activated if they encounter foreign antigens. It's constantly monitoring the tissues. But this network can also be a route for disease spread.
How so?
Microbes or tumor cells can get into the lymphatics and travel to regional lymph nodes and potentially spread systemically.
A double-edged sword. Okay, to wrap up this section on normal structure and function, what are the absolute key takeaways?
Okay, three main things. One, the basic three-layer design intima, media, adventitia for most vessels except capillaries. Two, the composition, especially SMCs and ECM, is highly adapted to local function and pressures. Three, this specific structure influences how vessels get injured and what diseases they're prone to.
That's a fantastic foundation.
Yeah.
Now, with that normal blueprint in mind, let's look at cases where the design deviates right from the start. Congenital vascular anomalies.
Right. Vascular anomalies are basically anatomical variations present at birth. Many are completely harmless, asymptomatic. But recognizing them is crucial, especially for surgeons or interventionalists. You don't want surprises if you're putting in a stent or operating nearby.
Knowing the plumbing map before you start work.
Exactly. And while there's a huge range, a few specific anomalies have more clinical significance. Let's talk about arteriovenous fistulas first. What does that name suggest?
Fistula, like an abnormal connection between an artery and a vein, bypassing the capillaries.
Spot on. An AV fistula is a direct shunt between an artery and a vein. It can be developmental, present from birth, or acquired later from things like trauma or inflammation.
And the impact depends on the size.
Very much so. Small ones, usually no big deal hemodynamically, but large ones can cause major problems. Blood gets shunted from the high-pressure artery straight into the low-pressure vein, increasing the amount of blood returning to the heart.
So higher cardiac output.
Yes, and lower overall peripheral resistance because you're bypassing the high-resistance capillary beds. In severe cases, this extra workload can actually lead to high-output heart failure.
Wow. And locally.
Locally, the tissues downstream from the bypass capillaries might not get enough blood, causing ischemia, and the fistula itself can potentially rupture due to the abnormal pressures.
So a circulatory shortcut with potentially serious consequences. Okay, next anomaly. Fibromuscular dysplasia. Sounds like abnormal muscle and fibrous tissue in the wall.
That's essentially it. Fibromuscular dysplasia, or FMD, is this focal, irregular thickening in the walls of medium and large muscular arteries. It's not atherosclerosis, not inflammation. The renal arteries and carotids are common spots. We don't fully know the cause, maybe genetic, maybe hormonal influences.
And what's happening in the wall?
You get these patches of thickening because of too much smooth muscle growth, medial hyperplasia, and also intimal hyperplasia, plus extra fibrous tissue, collagen. This narrows the lumen, causes stenosis.
And if it hits the renal arteries?
That's a big cause of secondary hypertension, especially in younger people. The kidney senses reduced blood flow and ramps up the renin-angiotensin system, driving up blood pressure.
You often hear about a string of beads appearance on angiograms with FMD. What causes that?
Right. That's because these thickened segments often alternate with areas where the media is actually abnormally thin. So on the angiogram, you see narrow bits alternating with slightly dilated bits, looks like beads on a string. And those thin segments, they can weaken and bulge out, forming aneurysms, which carry a risk of rupture.
So both narrowing and weakening in the same vessel. The last one you mentioned was anomalous coronary artery origin. That sounds inherently risky, given it's the heart supply.
It certainly can be. Normally, the coronary arteries arise from specific spots, the right and left aortic sinuses. Anomalous origin means they come from somewhere else. A particularly dangerous scenario is when both coronaries arise from the same aortic cusp, and one of them, in its path, runs between the aorta and the pulmonary artery.
Why is that specific route so bad?
Because during exercise, when pressures in the aorta and pulmonary artery increase, that aberrant coronary artery can get squeezed between them.
Cutting off its own blood flow.
Exactly, leading to myocardial ischemia. Tragically, this is a known cause of sudden cardiac death, especially in young athletes during exertion.
A sobering reminder of how critical normal anatomy is. Okay, we've seen how things can be different from the start. Now, how do vessels react to injury later in life?
This is where the interplay between endothelial cells, ECs, and smooth muscle cells, SMCs, becomes absolutely central. Their coordinated response dictates how vessels handle all sorts of challenges, hemodynamic stress, biochemical insults, everything.
Let's start with the endothelium, that inner lining. You said it's much more than just a passive barrier.
Oh, absolutely. ECs are incredibly dynamic. In their normal resting state, they maintain a non-thromogenic surface, keeping blood fluid. They actively regulate the tone of the underlying smooth muscle by releasing vasodilators like nitric oxide and vasoconstrictors like endothelin.
So they control vessel diameter and resistance.
They're major players in it.
Yeah.
They also metabolize hormones like converting angiotensin acea to the potent vasoconstrictor angiotensin II via ACE on their surface. They regulate inflammation by controlling leukocyte traffic. They influence SMC growth, and normally the junctions between them are tight, restricting leakage.
But they can become leaky.
Yes, for instance, histamine makes them contract temporarily, opening small gaps for fluid and proteins to escape quickly. And during inflammation, leukocytes need to migrate between them to get to the tissue.
A highly regulated barrier. What happens when it gets activated?
Endothelial activation is a shift in function in response to various stimuli. Think cytokines from infection, bacterial products, turbulent blood flow, high lipids, high glucose, like in diabetes, viruses, complement activation, hypoxia. The list is long.
And how does their behavior change when activated?
They undergo a major shift. They start expressing adhesion molecules on their surface, grabbing hold of passing leukocytes. They churn out cytokines and chemokines, amplifying inflammation. Their balance of vasoactive molecules can shift, often becoming more vasoconstrictive. They can express MHC molecules to present antigens. And crucially, their balance of procoagulant and anticoagulant factors often tips towards promoting clot formation.
So activation makes them pro-inflammatory, pro-thrombotic, and affects vessel tone. What about endothelial dysfunction? Is that different?
Dysfunction is essentially a persistent pathological state of activation. It's considered a key early step in many vascular diseases: atherosclerosis, hypertension-related damage, thrombus formation. It's characterized by that pro-inflammatory, pro-thrombotic phenotype. It can be a quick reversible change, or it can involve longer-term changes in gene expression and protein production.
A maladaptive state. Now the other key cell, the smooth muscle cell, SMC.
SMCs are the main component of the media. Normally, they're pretty quiescent, just maintaining tone. But they have a remarkable ability to proliferate when stimulated by growth factors, cytokines during injury or inflammation. They're the main producers of the ECM, the collagen, elastin, proteoglycans that give the vessel wall its structure.
And they also produce signaling molecules themselves.
Yes, they make their own growth factors and cytokines, influencing other cells. And fundamentally, they're responsible for the actual contraction and relaxation that controls vessel diameter. They're crucial in normal repair, but also central players in diseases like atherosclerosis.
Okay. Now you introduced intimal thickening as a standard response to injury. What does that involve?
It's a really stereotyped reaction. Almost any kind of vascular injury or dysfunction triggers it. Essentially, SMCs, or their precursors, get recruited into the intima that normally thin inner layer. They migrate from the media or maybe even from the circulation.
And once they're in the intima.
They start to proliferate, multiply, and they lay down new ECM. This builds up the intima, making it thicker. Eventually, endothelial cells grow over this new layer, this neointima.
So it's like forming scar tissue, a healing response.
That's a good analogy. It is a healing response, but like scar tissue elsewhere, if it becomes excessive, it causes problems. Too much intimal thickening narrows the lumen, causes stenosis, and can obstruct blood flow.
The repair itself becomes the problem.
Okay.
Summing up this response to injury section, key points about ECs and SMCs.
Right. Key concepts. 1, the endothelium lines everything, but it's specialized locally. 2, EC function is tightly regulated, shifting between basal and activated states. Dysfunction is pathological. 3, injury triggers a standard healing response. SMCs move in, proliferate, make matrix, thickening the intima. 4, this SMC recruitment is driven by complex signals from ECs, platelets, immune cells. 5, excessive intimal thickening while trying to heal can lead to stenosis and blockage.
That really highlights the dynamic nature of the vessel wall. Okay, let's move to a huge topic, hypertensive vascular disease.
Yeah, maintaining blood pressure in the right range is critical. Too low hypertension organs don't get enough blood. Too high hypertension damages organs directly and massively accelerates atherosclerosis.
And it's not just high or not high, it's a spectrum of risk, isn't it?
Absolutely. Blood pressure is continuous. The higher it goes, the higher the risk. There's no magic threshold. Both numbers matter: systolic, the top number, and diastolic, the bottom number. Current guidelines define hypertension roughly as diastolic over 80 or systolic over 120. That captures a huge chunk of the adult population, something like 46%.
Though those cutoffs might be lower for some people, like diabetics.
Exactly. Risk assessment needs to be personalized.
Now, causes of hypertension, it's so common.
Hugely common. About 90% of cases are what we call essential or primary hypertension, meaning we don't know the specific underlying cause. It's likely multifactorial, a mix of genetic predispositions and environmental factors adding up.
And the other 10%.
That's secondary hypertension. There is an identifiable cause, maybe kidney disease, adrenal problems, renal artery stenosis, things like that. If you treat the underlying cause, the blood pressure often improves.
And who's more likely to get essential hypertension?
Well, prevalence definitely increases with age, and unfortunately, there are disparities. African Americans tend to have higher rates and often more severe consequences.
And the consequences go beyond just atherosclerosis.
Yes. Chronic hypertension leads to cardiac hypertrophy, heart failure that's hypertensive heart disease. It can cause multi-infarct dementia from damage to small brain vessels. It's a major risk factor for aortic dissection and chronic kidney disease leading to renal failure.
But it's often silent for years, right? The silent killer.
That's the danger. People can have significantly high blood pressure and feel perfectly fine for a long time. That's why screening is so vital. Untreated, it leads to premature death from heart attacks, heart failure, stroke. But the good news is treatment with medication dramatically reduces these risks.
That's crucial. Now, what about malignant hypertension? That sounds particularly bad.
It is. It's a medical emergency. Affects maybe 1–5% of hypertensive people. Blood pressure skyrockets rapidly systolic, often over 200, diastolic over 120. It causes acute end organ damage, renal failure, brain swelling, encephalopathy, severe retinal hemorrhages, often papilledema swelling of the optic nerve. Untreated, it's fatal within a year or two. It can pop up in someone who is previously normal or be superimposed on existing hypertension.
A really acute and dangerous escalation. Okay, let's get into the nuts and bolts of blood pressure regulation.
Yeah.
Complex system.
Very complex. It involves the heart, blood vessels, kidneys, nervous system, hormones, all interacting. You can think about it in terms of cardiac output, peripheral resistance, and blood volume.
Okay, cardiac output first.
Cardiac output is heart rate times stroke volume, how much blood the heart pumps per beat. Stroke volume depends on how much blood fills the heart, contractility, and the resistance the heart pumps against. Heart rate and contractility are heavily influenced by the autonomic nervous system. Sympathetic speeds things up, parasympathetic slows down.
And peripheral resistance, that's mainly the arterioles.
Predominantly, yes. Arterioles constricting or dilating changes resistance. This is controlled by nerves and hormones.
And blood volume.
That's tightly linked to sodium and water balance. Hormones like aldosterone and atrial natriuretic peptide play key roles, mainly via the kidneys.
So cardiac factors, humoral factors, hormones, neural factors, local factors, all feeding in.
It's a constant balancing act. Hormones like angiotensin II, catecholamines, endothelin constrict vessels. Others like prostaglandins, kinins, nitric oxide dilate them. Nerves provide adrenergic control. Alpha constricts, beta dilates. And locally, tissues can auto-regulate flow based on pH, oxygen levels.
And the kidneys seem central to long-term control.
Absolutely crucial. They control blood volume via sodium handling, and they run the renin-angiotensin-aldosterone system, or RAAS.
Okay, break down the RAAS for us.
Sure. When the kidney senses low pressure, low sodium, or gets sympathetic nerve stimulation, special cells called juxtaglomerular cells release an enzyme called renin.
Okay, renin is released. Then what?
Renin chops up a protein from the liver called angiotensinogen, making angiotensin I. Then another enzyme, ACE angiotensin converting enzyme, mostly on lung endothelial cells, converts angiotensin I to angiotensin II.
And angiotensin II is the main player.
It's a powerhouse. It's a potent vasoconstrictor, directly raising peripheral resistance. It tells the adrenal glands to release aldosterone, and it acts on the kidneys to increase sodium reabsorption, all of which raises blood pressure.
And aldosterone's role?
Aldosterone acts on the kidney's distal tubules, making them reabsorb more sodium and water and excrete potassium. More sodium and water means more blood volume, which increases blood pressure.
But the kidney also makes counter-regulatory substances.
Yes, things like prostaglandins and nitric oxide, which cause vasodilation, partly balancing angiotensin II. The kidneys and the heart also sense volume changes. The heart releases natriuretic peptides, ANP and BNP, when it's stretched by high volume.
And they do the opposite of RAAS.
Pretty much. They make the kidneys excrete more sodium and water, and they cause vasodilation, helping to lower blood pressure and volume. It's this intricate feedback loop.
Amazing system. Now, back to essential hypertension. The 90% where we don't know the single cause. What are the leading theories?
Well, genetics clearly plays a role. Twin studies, family histories show that. While rare single-gene defects cause specific hypertension syndromes by messing with kidney sodium channels or aldosterone, essential hypertension is likely polygenic, many genes with small effects adding up. Genome-wide studies have found lots of associated regions, but pinning down the exact mechanisms is ongoing.
So subtle genetic variations interacting. What about the kidney's role in essential hypertension?
A key idea is that maybe the kidneys aren't excreting sodium properly at normal pressures, this concept of pressure natriuresis being reset. To get rid of the sodium load, the body has to operate at a higher baseline pressure. This could lead to volume expansion, increased cardiac output, and eventually increased peripheral resistance.
So the kidneys need higher pressure to do their job. Other factors.
Increased vasoconstrictive influences, maybe overactive sympathetic nerves, maybe too much angiotensin or endothelin, maybe not enough nitric oxide, structural changes in the vessel walls themselves making them stiffer, and definitely environmental factors. Stress, obesity, smoking, inactivity, and crucially high salt intake, especially in people who are salt sensitive.
A real mix of nature and nurture. Now, what does chronic hypertension do to the blood vessels pathologically?
It accelerates atherosclerosis, definitely. It causes degenerative changes in big arteries, leading to dissection or hemorrhage risk, and it causes specific damage to small vessels, small arteries, and arterioles. We see two main patterns there.
Okay, what's the first one?
Hyaline arteriosclerosis. The arterial walls get thickened with this glassy pink hyaline material. It's basically plasma proteins that have leaked in due to endothelial injury, plus extra basement membrane material made by stressed, smooth muscle cells. It narrows the lumen. You see it with aging, but it's much worse in hypertension and diabetes. In the kidney, it causes nephrosclerosis scarring due to reduced blood flow.
And the second pattern, more severe.
Yes, hyperplastic arteriolosclerosis. This happens with more severe or malignant hypertension. The arterial walls develop this concentric laminated thickening, looks like onion skin layers. It's due to proliferating smooth muscle cells and reduplicated basement membranes. Again, it narrows the lumen. In malignant hypertension, you often see fibrinoid necrosis, protein deposition, and actual death of the vessel wall tissue, especially in the kidney. That's called necrotizing arteriolitis.
So hyaline is deposition, hyperplastic is proliferation, and necrosis. Okay, key points on hypertension's vascular pathology.
Hypertension, super common, major risk factor for atherosclerosis, heart failure, renal failure, often silent. Histologically causes arterial wall thickening hyaline deposits or smooth muscle proliferation, hyperplastic, in small vessels, narrowing the lumen and damaging organs downstream.
Got it. That gives us a clear picture of hypertensive damage. Now let's broaden the scope to arteriosclerosis in general.
Right. Arteriosclerosis just means hardening of the arteries, any thickening and loss of elasticity. Atherosclerosis is one type, the most important one, but there are others. We usually talk about four main
It's
patterns.
already covered arteriosclerosis, affecting the small vessels linked to hypertension. What are the other three?
Second is Munkeberg medial sclerosis. This is calcification, calcium deposits, specifically in the media, the middle layer of muscular arteries. Often starts along the internal elastic membrane. You see it mostly in people over 50.
Does it block the artery?
Usually not. The calcification is in the media. It doesn't typically encroach on the lumen. So while the artery is literally harder, it's often clinically insignificant.
Okay, interesting. Pattern number 3.
Fibromuscular intimal hyperplasia. We touched on this earlier as a response to injury. It's thickening of the intima and muscular arteries, bigger than arterioles, due to smooth muscle proliferation and matrix deposition. It's driven by inflammation, like in healed vasculitis or transplant rejection or mechanical injury from stents or angioplasty.
So it's a healing response that can go too far.
Exactly. It can cause significant stenosis. It's the main reason stents sometimes re-narrow in-stent restenosis, and it's a big problem in organ transplants, causing chronic rejection by narrowing the graft vessels.
Okay, and that leads the 4th pattern, the big one. Atherosclerosis.
Atherosclerosis, yes, the most frequent and by far the most clinically important. It underlies almost all coronary artery disease, most strokes, a lot of peripheral vascular disease. It's the leading cause of death and disability in the Western world, responsible for maybe half of all deaths. When you see stats for coronary artery disease mortality, it's mostly ischemic heart disease, and myocardial infarction alone accounts for, what, almost a quarter of U.S. deaths.
Staggering numbers. And it's driven by these intimal lesions, the atheromas or atherosclerotic plaques.
Right. These plaques are raised lesions in the intima. They have a soft, lipid-rich core, mostly cholesterol, covered by a fibrous cap made of smooth muscle cells and collagen.
And they don't just block flow.
No, that's only part of the story. The bigger dangers are plaque rupture, which triggers sudden clot formation, catastrophic thrombosis, or the plaque itself can weaken the underlying vessel wall, leading to aneurysm formation. The plaque also increases the diffusion distance for nutrients, starving the media.
A complex and dangerous lesion. What about the epidemiology? It's a global problem now.
Huge global problem. While rates have moderated somewhat in developed nations due to risk factor control and treatment, it's rising dramatically in low and middle-income countries as lifestyles change. Death rates are actually higher now in parts of Africa, India, Southeast Asia than in the U.S. Eastern Europe has rates several times higher than the U.S. Japan, interestingly, has much lower rates.
Stark differences. Let's get into the risk factors. You split them into non-modifiable and modifiable. Start with the ones we can't change.
Okay, non-modifiable or constitutional factors. Genetics is big family history of early heart disease is a major red flag. Age atherosclerosis is progressive. Clinical events ramp up significantly after age 40-50. Male gender men are at higher risk than premenopausal women, though the gap closes dramatically after menopause, likely due to estrogen's protective effects diminishing.
Anything else in the non-modifiable category?
There's emerging evidence about something called clonal hematopoiesis, CHIP. It's an age-related thing where blood stem cells pick up mutations and certain clones expand. These clones seem to be linked to increased inflammation and atherosclerosis risk, so maybe another aspect of aging contributing.
Fascinating link between blood cells and arteries. Now, the modifiable factors, the ones we can theoretically control.
These are the big targets for prevention and treatment. Hyperlipidemia is number one, specifically high LDL, the bad cholesterol, and low HDL, the good cholesterol. LDL delivers cholesterol to the vessel wall, HDL helps remove it. Lowering LDL with diet, and especially statin drugs, significantly cuts risk.
And statins work just by lowering cholesterol.
Primarily, they inhibit HMG-CoA reductase, a key enzyme in making cholesterol. But they also seem to have anti-inflammatory effects, which might be part of their benefit. And regarding diet, the thinking has shifted a bit. It's less about total fat, more about the types of fat. Omega-3 is good, trans fat's bad, and overall cholesterol balance.
Okay, so lipids are key. Next modifiable factor.
Hypertension, we've covered that major driver. Cigarettes, smoking, huge impact. Smoking damages endothelial cells, makes platelets stickier, promotes LDL oxidation, just bad all around for vessels.
And diabetes?
Another massive risk factor. Diabetes accelerates atherosclerosis dramatically. It causes endothelial dysfunction, promotes dyslipidemia, increases inflammation through things like advanced glycation end products, AGEs, makes people more prone to infection, a perfect storm for vascular disease.
And inflammation itself.
Now recognized as a central, modifiable risk factor. Inflammation is present at every stage of plaque development. Markers like C-reactive protein, CRP, actually add predictive value beyond traditional risk factors. Targeting inflammation is a major focus of research.
So lipids, blood pressure, smoking, diabetes, inflammation, the major modifiable culprits. You mentioned some additional ones too.
Yeah, factors that contribute, especially when the major ones aren't sky high. Things like hyperhomocystinemia, high homocysteine levels correlate with risk, though direct causality is debated. Metabolic syndrome, that cluster of obesity, insulin resistance, hypertension, dyslipidemia, pro-inflammatory state, big risk magnifier. High lipoprotein, or LPA, it's genetically determined, looks like LDL, and is an independent risk factor. Factors affecting clotting, like high PAI1, which inhibits clot breakdown, and lifestyle things, lack of exercise, chronic stress, obesity itself.
A complex web. Okay, let's get into the how. The pathogenesis, the response to injury hypothesis.
Right, that's still the dominant framework. It views atherosclerosis as this chronic inflammatory and healing process triggered by injury or dysfunction of the endothelium. It's an intricate dance between lipids, macrophages, T cells, endothelial cells, and smooth muscle cells.
Walk us through the steps, starting with that initial injury.
Okay, step 1, endothelial injury or dysfunction. Caused by all those risk factors we just listed, high lipids, hypertension, smoking, toxins, turbulent blood flow. Areas where blood flow is disturbed, like at artery branches, are particularly susceptible. Laminar, smooth flow, is actually protective. It induces genes like KLF2 that keep ECs quiescent. Turbulent flow does the opposite. High LDL directly damages ECs, increasing oxidative stress. Inflammation obviously plays a role via cytokines.
So the lining gets damaged or activated. What's next?
Step 2. Lipids start accumulating in the intima, mainly LDL, especially oxidized LDL. The damaged endothelium is more permeable. Step 3. Monocytes stick to the activated endothelium, squeeze into the intima, and transform into macrophages. These macrophages then gobble up the accumulated lipids, becoming foam cells.
Foam cells, the hallmark of early lesions, fatty streaks.
Exactly. Fatty streaks are the earliest visible lesions. They're basically collections of foam cells. They don't always progress, but they're the start. Step 4, platelets might adhere to injured areas. Step 5, all these activated cells, macrophages, platelets, ECs, even SMCs release signaling molecules, growth factors, cytokines. These signals recruit smooth muscle cells into the intima.
Migrating from the media.
Mostly from the media, yes, or maybe from circulating precursors. Step 6. These SMCs in the intima start to proliferate, and they produce ECM, collagen, etc. T cells also get recruited into the lesion. Step 7. More lipid accumulation, both inside cells, macrophages, SMCs, and outside. Oxidized LDL is particularly nasty. It's toxic and keeps stimulating inflammation. Cholesterol crystals themselves can trigger inflammasomes in macrophages, leading to IL-1 release, pulling in more inflammatory cells. It's a vicious cycle.
A self-perpetuating cycle of lipid buildup and inflammation.
And step 8, late stage. Calcification of the matrix and necrotic debris within the core of the plaque.
You really emphasize the role of inflammation. It seems central.
Absolutely central, from initiation through progression and complications. Those cholesterol crystals, fatty acids activating inflammasomes, producing IL-1, recruiting more macrophages and T cells. Activated macrophages make reactive oxygen species, oxidizing more LDL, and growth factors driving SMC proliferation. Activated T cells release cytokines like interferon gamma, further activating macrophages and other cells. It's chronic, smoldering inflammation in the artery wall.
And what about infection? Any role there?
There's been speculation about viruses like CMV or bacteria like chlamydia and pneumonia, but honestly, no clear causal link has ever been established. The focus remains firmly on the lipid-driven inflammatory response to injury model.
Okay, so smooth muscle proliferation and matrix synthesis, how do they shape the plaque?
They're what convert that early fatty streak into a mature, complex atheroma. The SMCs proliferating and laying down collagen builds the bulk of the plaque, especially the fibrous cap. Growth factors like PDGF from platelets, macrophages, ECs, SMCs, FGF, TGF-alpha drive this. Collagen gives the plaque structure stability. But inflammation also influences matrix breakdown. Inflammatory cells release MMPs, matrix metalloproteinases, enzymes that chew up collagen. So the balance between synthesis and degradation is critical for plaque stability.
A constant remodeling. Okay, let's talk morphology. What do these plaques look like?
Grossly, they're raised, yellowish tan lesions inside the artery. Patchy, eccentric, they don't usually wrap all the way around. They have preferred locations. Worst in the lower abdominal aorta and iliacs, then coronaries, popliteals, behind the knee, internal carotids, circle of Willis in the brain, arms, mesenteric, renal arteries, except right at the opening, tend to be spared.
Specific targets,
Yep.
under the microscope.
It's a mix of cells, SMCs, macrophage foam cells, T cells, ECM, collagen, elastin, proteoglycans, lipids, intra and extracellular, and often calcium later on. Structurally, you see a superficial fibrous cap, mostly SMCs and dense collagen. Then the shoulder is more cellular with macrophages, T cells, SMCs. And deep to the cap, the necrotic core lipids, debris, foam cells, fibrin, cholesterol crystals, which look like empty slits after processing. There's often neovascularization, little leaky new blood vessels at the edges. Plaques are dynamic, they change, grow, calcify, organize bits of thrombus over time. The cap thickness is key to stability.
Thick cap, more stable. Thin cap, more dangerous.
Generally, yes. Now let's talk about acute plaque change, the sudden events. Right. This is when a plaque suddenly disrupts, usually leading to thrombosis clot formation, which causes the acute event, like a heart attack or stroke. 3 main ways this happens. 1, rupture or fissuring of the fibrous cap. This exposes the thrombogenic core contents to blood, triggering clotting. 2, erosion or ulceration of the plaque surface. Exposes the subendothelial basement membrane, also thrombogenic, but maybe less catastrophically than a rupture. 3, hemorrhage into the plaque itself from those leaky neovessels. This can rapidly expand the plaque volume.
And critically, these dangerous plaques often weren't causing severe blockage beforehand.
That's a crucial point. Many plaques that rupture and cause MIs were only causing mild or moderate stenosis. It's not just about how much blockage, it's about plaque vulnerability. Angiograms mainly show the lumen size, not the plaque composition.
So what makes a plaque vulnerable, prone to rupture?
It's a balance of mechanical stress versus plaque strength. Stress comes from blood pressure, flow forces. Strength comes mainly from the fibrous cap. A vulnerable plaque typically has a thin fibrous cap, lots of inflammatory cells, macrophages releasing those MMPs that degrade collagen, and a large lipid core. Intrinsic factors, plaque structure, and extrinsic factors, blood pressure spikes, platelet activation, vasospasm can trigger rupture. Vasoconstriction is also bad, increases shear stress on the plaque. And remember, not all ruptures cause occlusion. Small, silent ruptures with minor thrombosis probably happen all the time, and their healing contributes to plaque growth. But when a major thrombosis occurs, that's the acute coronary syndrome. Thrombi can also embolize downstream, causing microinfarcts, and thrombin itself stimulates SMCs, feeding back into plaque growth.
A really unstable situation. So major consequences of atherosclerosis.
Heart attack, MI, stroke, cerebral infarction, aortic aneurysms, wall weakening, peripheral vascular disease, leg ischemia, gangrene. Primarily hits large elastic and medium muscular arteries, aorta, carotids, iliacs, coronaries, popliteals. Also atheroembolism, plaque debris showering downstream, and aneurysm formation due to medial weakening.
Okay, summing up atherosclerosis, the absolute essentials.
It's an intimal lesion, fibrous cap over a lipid core, driven by injury and chronic inflammation, fueled by risk factors causing EC dysfunction and recruiting inflammatory SMC cells, develops slowly over decades. Stable plaques cause chronic ischemia by narrowing. Unstable plaques cause acute events via rupture, thrombosis, embolization. Stable is thick cap, less lipid, less inflammation. Vulnerable, thin cap, large core, high inflammation.
Excellent summary of a very complex process. Now let's move to aneurysms and dissection. Related but different problems with vessel wall integrity.
Right. An aneurysm is an abnormal localized dilation of a blood vessel involving all 3 wall layers. Can be congenital or acquired. True aneurysms bulge outwards, either saccular like a berry or fusiform, spindle-shaped. A false aneurysm or pseudoaneurysm is different. It's a rupture contained by surrounding tissue, forming a hematoma that still communicates with the lumen. And a dissection is when blood gets into the wall itself and splits the layers, creating a false channel.
And all can rupture.
Yes, that's the major danger for all 3, potentially catastrophic hemorrhage.
So what causes the wall to weaken and lead to aneurysms?
It's fundamentally about compromised connective tissue structure or function. Several factors. 1, intrinsically poor quality tissue, like defective collagen and Ehlers-Danlos syndrome. 2, abnormal TGF-beta signaling. Too much TGF-beta activity messes up ECM remodeling, especially in the aorta, leading to weakened walls. This is seen in Marfan syndrome. Defective fibrillin leads to excess active TGF-beta, and Loeys-Dietz syndrome, mutations in TGF-beta pathway itself.
So genetic signaling pathways are critical. What else weakens the wall?
An imbalance in matrix turnover. Inflammation, like in atherosclerosis or aortitis, brings in cells that release MMPs, enzymes that degrade collagen and elastin. If TIMPs, the inhibitors of MMPs, are overwhelmed, the matrix breaks down. Loss of elastin is particularly bad for aortic recoil. Also, loss of smooth muscle cells or if they make abnormal ECM. Ischemia of the media can also weaken it, either from thick intima blocking diffusion from the lumen or from hypertension narrowing the vasa vasorum supplying the outer media. Tertiary syphilis used to be a cause via vasorum damage.
A lot of ways to undermine the wall. Other risk factors.
Age, definitely. Smoking, trauma, vasculitis, congenital defects like FMD or Berry aneurysms, infections, mycotic aneurysms from bacteria or fungi directly attacking the wall.
Let's focus on abdominal aortic aneurysms, AAAs. They're quite common, right? Where do they typically form?
Usually below the renal arteries down to the bifurcation into the iliacs. Can be saccular or fusiform, defined as 3-centimeter diameter, often much larger. The underlying pathology is severe atherosclerosis, causing medial destruction and thinning. Often have a layered thrombus inside. Can involve renal or mesenteric artery origins. Often coexist with iliac aneurysms.
And how do they present clinically?
Often asymptomatic, found incidentally as a pulsating mass on exam, but can cause rupture, massive bleed, obstruction of branch arteries, causing leg, kidney, gut ischemia, emboli from the thrombus, or compression of adjacent structures like ureters or vertebrae.
And rupture risk scales with size.
Dramatically. Below 4 centimeters, risk is very low. 4 through 5 centimeters, maybe 1% per year. 5-6 centimeters jumps to 11% per year. Over 6 centimeters, maybe 25% per year. They tend to grow 0.2 to 0.3 centimeter. Once they hit 5 centimeters or so, intervention, surgery, or endovascular stent graft is usually recommended.
What about mycotic or inflammatory AAAs?
Mycotic means infected bacteria seeding the wall, leading to rapid weakening and rupture risk. Inflammatory AAAs have dense fibrosis and inflammation around them, sometimes linked to IgG4-related disease, a systemic inflammatory condition. They might respond to immunosuppression.
Okay. Now, aortic dissection, different process.
Completely different. Here, blood gets inside the aortic wall, splitting the layers of the media, forming a false channel, often associated with aortic dilation. The big danger is rupture outwards through the adventitia.
Who gets dissections? 2
main groups: men aged 40-60, almost always with hypertension, 90% of cases, and younger patients with connective tissue disorders like Marfan or Loeys-Dietz. Other causes: iatrogenic, catheters, pregnancy, hormonal hemodynamic stress, less commonly linked to atherosclerosis itself.
So hypertension and weak walls again. How does it start?
Usually with an intimal tear. Why the tear happens isn't always clear. Once it tears, high-pressure blood forces its way into the media and starts splitting it apart. Reducing blood pressure aggressively is key to stopping it from propagating further. Sometimes it might start with bleeding from the vasa vasorum within the wall, creating a hematoma that then tears the intima.
And where does the tear usually occur?
Most often in the ascending aorta, near the valve. Usually a transverse tear. The dissection can rip backwards towards the heart or forwards down the aorta, even into leg arteries. It splits the media, usually in the outer third, or between media and adventitia. Rupture leads to massive bleeding, cardiac campanode. Sometimes it re-enters the true lumen further down, creating a double-barreled aorta, a chronic dissection. Traumatic tears, like from car crashes, often happen at the aortic isthmus.
A truly dramatic and dangerous event. Okay, summary for aneurysms and dissection.
Aneurysms equal dilations, risk rupture thrombosis embolism. Dissections is blood in the wall, risk rupture obstruction. Both result from wall weakness due to things like bad TGF-beta signaling, SMC loss, ECM problems from ischemia, genetics, or bad remodeling.
Got it. Now let's switch gears to vasculitis, inflammation of the vessel walls.
Right. Vasculitis is a whole group of disorders where the vessel walls themselves become inflamed. The symptoms are incredibly varied depending on which vessels are hit size, location. Can cause systemic symptoms like fever, aches, malaise, plus specific organ damage from ischemia.
Lots of different types.
Many primary forms. We classify them based on vessel size, large, medium, small, the type of inflammation, granulomas, giant cells, ANCA positivity. Examples include giant cell arteritis, Takayasu, polyarteritis nodosa, PMN, Kawasaki, microscopic polyangiitis, GPA, Church-Strauss, Berger disease, each with its own pattern.
And what causes the inflammation?
2 main paths: immune-mediated inflammation or direct infection of the vessel wall. Infections can also trigger immune responses that cause non-infectious vasculitis. Distinguishing immune versus infectious is critical for treatment. Immunosuppression helps immune forms but harms infectious ones. Physical or chemical injury can also cause it sometimes.
Let's focus on the non-infectious immune-mediated types, immune complex deposition.
Yeah, this happens in diseases like lupus or can be triggered by drugs or infections. Antigen-antibody complexes form, deposit in vessel walls, activate complement, attract neutrophils, cause damage. Think serum sickness type reactions. Drug hypersensitivity vasculitis is a classic example. Drug acts as antigen, forms complexes, causes skin lesions, purpura. Stop the drug, it usually resolves.
Second big mechanism, ANCAs, anti-neutrophil cytoplasmic antibodies.
Right. These are autoantibodies against proteins inside neutrophil granules. Two main types based on targets. PR3-ANCA, also called C-ANCA, is linked mainly to granulomatosis with polyangiitis, GPA. MPO-NCA, PNCA, is linked to microscopic polyangiitis and Churg-Strauss. ANCA levels often track disease activity.
And how do they cause damage?
They can actually bind to neutrophils, especially if the neutrophils are activated and express PR3-MPO on their surface, and trigger them to release damaging enzymes and reactive oxygen species right into the endothelium. So the antibodies directly incite the neutrophils to attack the vessel wall. Interestingly, these vasculitides are often pauciimmune, not much antibody or complement deposited in the tissue itself, suggesting this direct neutrophil activation mechanism is key.
A direct hit mechanism. What about anti-endothelial cell antibodies, or T cells?
Anti-EC antibodies, AECAs, might play a role in some, like Kawasaki disease. And autoreactive T cells attacking vascular self-antigens, are likely important in several forms, causing inflammation through cytokines or direct killing.
Okay, let's run through some specific vasculitides. Giant cell arteritis, temporal arteritis, affects older people, head arteries.
Correct. Most common vasculitis in the elderly. Chronic granulomatous inflammation of large medium arteries, especially temporal, vertebral, ophthalmic arteries, causes intimal thickening. Medial granulomas often centered on the internal elastic lamina, which gets fragmented. T-cell macrophage infiltrates, often giant cells. Lesions are patchy, so biopsy needs a decent length, 1 centimeter, and negative doesn't rule it out. Symptoms can be vague, fever, fatigue, or specific headache, jaw pain, visual loss, which is an emergency. Responds well to steroids.
Kakiyasu arteritis. Similar but younger patients, aorta and branches.
Yes, pulseless disease. Granulomatous vasculitis of medium-large arteries, especially aortic arch and its branches. Causes thickening, fibrosis, severe narrowing. Histology can look like GCA, but age 50 is typical. Affects aorta, carotid, subclavians, renals, pulmonary arteries. Causes weak pulses, visual problems, hypertension. Also treated with immunosuppression.
Polyarteritis nodosa, perionin. Medium vessels, spares lungs, linked to Hep B.
Right. Systemic necrotizing vasculitis of small medium muscular arteries, kidneys, heart, liver, GI tract usually involved. Lungs spared, no ANCA link. About a third have chronic Hep B, immune complexes might be involved there. Cause unknown in most. Presents with ischemia infarction in affected organs. Kidney failure is a big risk. Segmental transmural necrosis, aneurysms, thrombosis. Lesions of different ages often coexist. Untreated is often fatal, but immunosuppression works well for many.
Kawasaki disease, infants, kids, coronary arteries.
Exactly. Acute, febrile, self-limited illness, mostly kids 4. Big worry is coronary artery aneurysms, which can rupture or thrombose, causing MI. Thought to be triggered by infection, causing delayed hypersensitivity, maybe anti-EC antibodies involved. Vasculitis looks a bit like PAN. Treat with IV and aspirin to prevent aneurysms.
Microscopic polyangiitis.
Yeah.
Small vessels, pauciimmune, MPO, and CA positive.
Yep. Necrotizing vasculitis of capillaries, venules, small arteries, lungs, capillaritis, hemorrhage, and kidneys. Glomerulonephritis, very commonly hit. Most are MPO-ANCA positive, likely triggered by immune responses to drug spugs, leading to ANCA production and neutrophil-mediated damage. Presents with things like hemoptysis, hematuria, purpura, responds to immunosuppression.
Granulomatosis with polyangiitis, GPA. The triad, respiratory tract granulomas, vasculitis, kidney disease, PR3-ANCA.
That's the one. Necrotizing granulomas in upper-lower airways, necrotizing vasculitis, small medium vessels, SB later lung stairways, and glomerulonephritis can be limited or widespread, likely T-cell response to inhaled antigen. Up to 95% are PR3-ANCA positive, which tracks disease, causes sinusitis, lung nodule scabities, kidney failure. Immunosuppression is key.
Churg-Strauss, EGPA, asthma, eosinophilia, granulomas.
Yes. Small vessel necrotizing vasculitis with that allergic phenotype. Asthma, rhinitis, eosinophils, eosinophilic granulomas in tissues vessels. Skin, GI, kidney involved. Heart involvement, eosinophilic cardiomyopathy, is a major cause of death, likely hyperresponse to allergen. Minority are MPO-ANCA positive. Distinct histology with eosinophils and granulomas.
Thromboangiitis obliterans, Burger disease, young smokers, extremities.
Almost exclusively heavy smokers, usually under 35. Segmental, thrombosing inflammation of medium-small arteries and veins and extremities. Tibial radial leads to severe ischemia, pain, nerve involvement common, ulcers, gangrene, strong link to tobacco, direct toxicity or immune response. Inflammation involves thrombus, often with microabscesses, vessel wall, and often extends to adjacent nerve vein. Smoking cessation is absolutely critical, especially early on.
And finally, vasculitis linked to other diseases or infections.
Vasculitis can occur with rheumatoid arthritis, lupus, cancers, cryoglobulinemia, antiphospholipid syndrome, Henoch-Schönlein purpura. Looks like PAN or hypersensitivity vasculitis. Treating the underlying disease is key. Infectious vasculitis is direct invasion by bugs, bacteria, fungi, weakening walls, mycotic aneurysms, or causing thrombosis infarction.
Wow, that's a huge range. Key concepts for vasculitis.
Inflammation of vessel walls, systemic symptoms plus organ damage based on vessels involved, mostly immune-mediated complexes, ANCAs, anti-EC-ABs, T cells. Less often infectious, different types hit specific vessel sizes locations.
Okay, let's shift to disorders of blood vessel hyperreactivity, excessive constriction.
Right, where vessels clamp down inappropriately. The main example is Raynaud phenomenon.
The fingers turning white, blue, then red in the cold.
Exactly. Exaggerated vasoconstriction of arteries, arterioles, and extremities, fingers, toes mostly, but nose, ears too, due to cold or emotion. Pallor, white from no flow, then cyanosis, blue from stagnant deoxygenated blood, then rubor, red from reactive rush of blood back in.
Is it always serious?
There's primary Raynaud's and secondary. Primary is commoner, mostly young women, symmetric, usually benign, seems to be intrinsic smooth muscle hyperreactivity. Secondary Raynaud's is due to an underlying disease causing vascular compromised scleroderma, lupus, Buerger's, atherosclerosis. Tends to be asymmetric, more severe, can cause ulcers or gangrene. New onset Raynaud's needs investigation for underlying causes.
So primary is mostly an annoyance. Secondary could be a sign of something serious. What about myocardial vessel vasospasm?
This is spasm of the coronary arteries themselves. Prinzmetal angina is the classic syndrome, chest pain at rest, often cyclic due to transient coronary spasm, can happen with or without underlying fixed blockages, can cause ischemia, MI, arrhythmias, sudden death. Etiology isn't totally clear. Maybe abnormal tone regulation, endothelial dysfunction, hypersensitivity to constrictors, low nitric oxide, treat with vasodilators like nitrates, calcium channel blockers.
Even the heart's own supply lines can spasm. Okay, let's move downstream to veins and lymphatics. Varicose veins first.
Very common. Dilated, tortuous superficial veins, usually in legs, saphenous system, caused by prolonged high pressure inside the vein and failure of the valves wall support. Obesity, pregnancy, standing a lot are risks. Leads to pooling, congestion, edema, pain, thrombosis risk, skin changes, stasis dermatitis, ulcers.
And varices elsewhere.
Yes. Portal hypertension from liver cirrhosis causes esophageal varices, dangerous, risk of massive bleeding if they rupture, hemorrhoids, rectal varices, caput medusae around umbilicus. Hemorrhoids can also be primary varicose veins at the anorectal junction from straining pregnancy, cause discomfort, bleeding, thrombosis.
Okay. Thrombophlebitis, phlebothrombosis, clots in veins.
Essentially, yes. Deep vein thrombosis, DVT is the main concern, 90% in deep leg veins.
Yeah.
Stasis, immobilization, long travel, post-op is the biggest risk factor. Others, heart failure, pregnancy, oral contraceptives, cancer, obesity, hypocoagulable states, genetics, or paraneoplastic like Trousseau syndrome with adenocarcinomas.
And they're often silent.
Up to half are asymptomatic. Symptoms, pain, swelling, redness, warmth, can be unreliable. The big danger is pulmonary embolism, PE. Clot breaks off, travels to lungs, potentially fatal. PD is often the first sign of DVT.
Scary. What about superior and inferior vena cava syndromes?
SVC syndrome, obstruction of the superior vena cava, usually by lung cancer, lymphoma, pressing on it, or catheter thrombus, causes backup of blood from head, neck, arm swelling, cyanosis, dilated veins, respiratory distress. IVC syndrome, obstruction of inferior vena cava, tumors like liver, kidney cancer growing into it, or thrombus propagating up, causes leg edema, abdominal wall collateral veins, massive proteinuria if renal veins involved.
And lymphatics, lymphangitis and lymphedema.
Lymphangitis is acute inflammation of lymphatic channels, usually bacterial strep. See red, painful streaks tracking up limb swollen nodes. Lymphedema is chronic swelling due to impaired lymphatic drainage. Fluid accumulates in tissues. Can be primary, rare congenital defect, or secondary commoner. Node removal for cancer, radiation, tumor blockage, infection like filariasis, scarring. Causes chronic, often firm, non-pitting edema, skin thickening, peau d'orange, increased risk of infection, and rarely lymphangiosarcoma.
Okay, that covers veins and lymphatics. Now, vascular tumors. Benign first.
Benign ones usually look like vessels lined by normal endothelium. Malignant ones, angiosarcomas, are more cellular, atypical, disorganized. Need markers like CD31, VWF to prove endothelial origin.
Benign conditions. Vascular ectasias.
Ectasia, dilation. Telangiectasia, dilated small superficial vessels, skin mucosa, red spots lines. Nevus flammeus, birthmark, flat pink-purple patch, dilated capillaries, often regresses. Port wine stain, type of nevus flammeus, persists, thickens skin. If in trigeminal distribution, can be part of Sturge-Weber syndrome with brain vascular malformations, seizures, etc. Spider telangiectasia, central arterial with radiating capillaries, blanchable, seen in pregnancy, liver disease.
Hemangiomas. True benign tumors.
Yes, common. Capillary hemangioma is most frequent dense capillaries. Juvenile strawberry hemangioma of infancy grows, then usually regresses. Cavernous hemangioma, large dilated spaces, deeper tissues don't regress. Pyogenic granuloma, rapid red growth, bleeds easily, often after trauma or in pregnancy on gums. Not actually granuloma.
Lymphangiomas, lymphatic equivalent.
Right. Simple capillary lymphangioma, small, superficial. Cavernous lymphangioma, cystic hygroma, large cystic masses, often neck axilla in kids associated with Turner syndrome, contain lymph, not blood.
Glomus tumor, bacillary angiomatosis.
Glomus tumor is benign but painful from modified SMCs in glomus bodies, thermoregulation, often under fingernails. Bacillary angiomatosis is a vascular proliferation caused by Bartonella bacteria, cat scratch, trench fever organisms, in immunocompromised AIDS. Red skin nodules masses, also bone brain, response to antibiotics. Bacteria-induced VEGF.
Intermediate grade, Kaposi sarcoma, linked to HHV8.
Yes, KS is caused by HHV8, KSHV. Vascular neoplasm, most common in AIDS. 4 forms: classic older Mediterranean men, legs, slow. Endemic, Africa, aggressive in kids. Transplant-associated immunosuppression can regress if reduced. AIDS-associated, most common, use Europe, aggressive anywhere. HHV8 affects ECs, drives proliferation angiogenesis via viral proteins, disrupts cell cycle control, progresses patch plaque nodules, spindle cells, slits with RBCs. Treatment depends on type.
And malignant, angiosarcoma.
Malignant tumor of endothelial cells. Can look well differentiated, like hemangioma, or totally anaplastic. Older adults often skin-soft tissue breast liver. Can arise in chronic lymphedema, lymphangiosarcoma, post-radiation, near foreign material. Hepatic forms linked to arsenic, thorotrast, vinyl chloride. Starts as red papules nodules, grows into fleshy masses. Needs CD31 VWF stain to confirm. Aggressive, metastasizes readily, poor prognosis, 30% 5-year survival.
A grim picture for angiosarcoma. Finally, let's touch on the pathology of vascular interventions when our treatments cause issues.
Right. Stenting, bypass grafts. They involve injury, thrombosis risk, abnormal forces, all of which can trigger that same intimal hyperplasia response we talked about.
Endovascular stenting first, for coronary arteries.
Yeah. Balloon angioplasty opens a blockage, but recoil or dissection can cause reclosure. Stents, metal mesh tubes, prop the artery open, prevent recoil, tack down dissections. But placing the stent injures the endothelium, triggers clotting, need antiplatelets, and crucially stimulates that healing response.
Leading to instant restenosis.
Exactly. Smooth muscle cells grow into the stent, deposit matrix, re-narrowing the lumen. This was a big problem with early bare metal stents, maybe a third restenosed within a year.
So drug-eluting stents, DES, were the answer.
They helped a lot. DES release drugs like paclitaxel, sirolimus that inhibit SMC proliferation, cutting restenosis rates dramatically. But the downside is they also slow down reendothelialization, the healing of the lining over the stent struts. This leaves the stent exposed to blood longer, increasing the risk of late stent thrombosis, which is dangerous. So patients need longer courses of dual antiplatelet therapy. Newer DES try to optimize this balance.
A trade-off. What about vascular replacement, like bypass grafts?
Large synthetic grafts, DECRA and PTFE, work okay for big vessels like the aorta, but small ones, 8 mm, tend to fail due to clotting or intimal hyperplasia at the connection points and anastomosis. For small vessels like coronary bypass, CABG, we prefer autologous grafts, the patient's own vessels.
Saphenous veins or internal mammary arteries.
Those are the main ones. Saphenous veins from the leg are used a lot, but their long-term patency isn't great, maybe 50% open at 10 years. They fail from early thrombosis, intimal hyperplasia, and later they develop atherosclerosis themselves within the vein graft. The left internal mammary artery, LIME, used typically for the LAD coronary, performs much better 90% patency at 10 years. It's an artery, resists atherosclerosis better, has better endothelial function.
Arteries make better arteries, it seems. Well, this has been an incredibly thorough journey through vascular pathology.
It really has. We've covered a tremendous amount of ground, from the fundamental structure right through to complex diseases and interventions. It just highlights how central the vascular system is to nearly every aspect of health and disease.
Absolutely. I feel like we've really built that deep, detailed framework we aimed for. Mastering this kind of information is, well, it's essential for truly understanding so much of medicine. It shows the vessel wall as this dynamic, responsive, but also vulnerable entity.
Couldn't agree more. And the field is constantly evolving. Our understanding of the molecular details, the genetic influences, the inflammatory pathways, it's advancing so rapidly. Which leads to a final thought, perhaps.
Go on.
Well, considering these ongoing advances, what breakthroughs are just over the horizon? What innovations in prevention, maybe in diagnostics or in targeted therapies, might fundamentally change how we deal with these incredibly common and often devastating vascular conditions in the future? That's the question that keeps driving the research.